The topic for discussion is clinical diagnosis and prognosis. So proper diagnosis is very much important in order to perform the treatment. So first we need to determine whether disease is present or not. So then if the disease is present, we need to identify the disease. What is the type of the disease? What is the severity of the disease and the extent of the disease? Finally, the diagnosis should provide an understanding of the underlying pathological processes and their causes. So first, we need to perform the overall appraisal of the patient. So we need to determine the attitude of the patient, we need to determine the temperament, we need to determine the physiologic age of the patient. So what is his attitude towards the treatment? Next, we need to take thorough health history or the medical history. So patients should be first explain about the importance of the medical history. Some patients might omit some information thinking that their medical history is not related to their dental problem. So patients should be explained about the role of the systemic diseases and their impact on the dental diseases, and also the dental diseases and their impact on the overall health status. Later, the patient should be asked if he or she has been hospitalized or has undergone any operations, or are they under any medication, are they under the care of physician, are they taking any medications that are prescribed, or are they taking medications that are obtained over the counter, and history of all the medical problems have to be taken, whether there are any abnormal bleeding tendency, whether there is any history of allergy present. Later, we need to take the dental history. In the dental history, we will obtain the information about the visits to the dentist. What is the current illness? Why has the patient visited the dentist? And what is the frequency of his dental visits? What is the date of the most recent visit? What is patient's oral hygiene regime? Is the patient under any orthodontic treatment, or the patient has undergone any implants in order to replace the missing teeth? Is the patient experiencing pain in the teeth or gums? Whether the patient had any history of periodontal problems. So all these have to be recorded in the dental history. Later, we will perform the photographic documentation. So this is an important part of the periodontal examination and diagnosis. So we will take the photographs. Digital photographic documentation is very important, and it is useful for record keeping, for education of both patient as well as the clinician, and also it will help us in communicating with the colleagues and also in planning the treatment. So photographs can provide the details that a clinician may not otherwise remember, and it will allow the clinician to evaluate the mouth even after the patient leaves, and it also helps us in monitoring the tissue changes that occur over the time. Next, we will learn about the clinical examination. So in the clinical examination, we will perform the examination of the extraoral structures. In this, the clinical examination, we will perform the examination of the temporomandibular joints, wherein we will assess for the pain, crepitus, clicking sounds, and the range of motion. The muscles of mastication should be palpated for pain and tenderness. So, because the periodontal, periapical, and other diseases will result in the lymph node changes, the clinician should routinely examine and evaluate the lymph nodes of the head and neck. Next, we will examine the oral cavity. So the entire oral cavity should be carefully examined. We need to assess the patient's oral hygiene, whether oral malodor is present or not. The lips, floor of the mouth, tongue, palate, vestibule, oropharyngeal region should be evaluated for any abnormalities and pathologies. Later, we will examine the periodontium. In the examination of periodontium, first you need to perform the visual examination of the biofilm and calicles. So immediately when the patient comes, you should not directly put a periodontal probe, because that will be very much uncomfortable for the patient. So first you need to examine for the biofilm and calicles, because those are the main factors that are responsible for the periodontal disease, isn't it? So first, you need to examine the biofilm and calicles. Later, you need to place the periodontal probe. So, in the first picture, you can see that the biofilm is present on the concavities along the gingival margin and in the interproximal spaces. In the next picture, you can see the inflammatory response in the marginal gingiva because of the biofilm accumulation on the tooth surface. So, you can see the inflammatory lesion on the marginal gingiva. In the next pictures, you can see that the subgingival calculus is visible on the tooth surface along the gingival margin. So this presence of this biofilm is associated with the inflammatory changes. So the subgingival calculus is visible through the marginal gingiva. So in the last picture, you can see that when the gingiva is retracted, it confirms the presence of the subgingival calculus, which is responsible for the inflammation. Next, we will perform the examination of the gingiva. So in this, what we will do is we will assess the width of the keratinized gingiva. So that is which extends from the gingival margin to the mucogingival junction. So the mucogingival junction can be appreciated, or it can be noted by stretching the lip and cheek, or by placing the probe horizontally in the vestibule and rolling the mucosa coronally. So by stretching or by placing the probe in the vestibule, and after placing the probe in the vestibule, you will roll the mucosa coronally. So here you can estimate the mucogingival junction, thereby you will know the width of the keratinized gingiva. So in the visual examination of the gingiva, you will notice the width of the gingiva, and you will notice any color changes in the gingiva. So usually the gingiva is coral pink in color. So if the gingiva is affected by periodontal disease, then the color will change to erythematous or cyanotic. So, and there will be knife edged margins in the healthy gingiva, but these margins will become rolled out in case of diseased gingiva. So the surface texture will become smooth and shiny in case of inflammation. So all these changes will be examined during the visual examination of the gingiva. So in this picture, you can notice that in the first picture, the gingiva is appearing smooth because it is covered by saliva. So in order to examine the gingiva, we need to dry the gingiva first. So once dried, we can see the surface texture, we can see the stippling. So always the saliva obscures the details. So therefore, drying of the gingiva is very much required in order to perform the proper evaluation. Now in the next picture, you see the marginal gingiva and the gingiva that is away from the marginal gingiva. So here you can see that the marginal gingiva is erythematous when compared to the gingiva that is present away from the gingival margin. In the next picture, you can see that the patient is having the physiologic pigmentation, that is melanin pigmentation, but still you can notice the erythema and edema that is present in the marginal gingiva. Now in this table, we will see the differences in between the healthy gingiva and the gingiva that is inflamed. So the healthy gingiva is coral pink or salmon pink, whereas the inflamed gingiva is erythematous and cyanotic. Whereas the consistency is firm and the gingiva is well adapted onto the tooth surface in case of healthy gingiva, whereas in the inflamed gingiva, the consistency is edematous, spongy, and the gingiva is loosely adapted. The contour is scalloped, knife-edged margin is present in healthy gingiva, whereas the contour is bulbous, swollen papillae and rolled papillae are seen in case of inflammation. The surface texture is stippled, so the depressions and elevations, those are called as stippling. Okay, that appearance is called as stippling. So stippling is seen in case of healthy gingiva, whereas smooth shiny surface is seen in case of inflamed gingiva. But however, remember an important point: stippling, the presence of stippling does not indicate a health status. Okay, so presence of stippling does not mean that the gingiva is healthy. Next, marginal bleeding is absent or slight bleeding is present in case of healthy gingiva, whereas moderate to severe marginal bleeding is seen. Probing depth is 2 to 3 mm, whereas the probing depth is greater than 3 mm if the gingiva is inflamed. Next, the tissue is resistant to probe penetration in case of healthy gingiva. Since it's healthy and firmly adapted, the probe will not penetrate. Whereas in case of inflamed gingiva, there will be minimal probe penetration. Okay, the bleeding on probing is absent or slight in case of healthy gingiva, whereas it is moderate to severe in case of inflamed gingiva. The pain on probing is absent or slight pain on probing is present, whereas moderate to severe pain on probing is seen in case of gingival inflammation. Next finding you need to examine is gingival recession. So recession is the apical migration of the gingiva. So the gingival position is migrated apically when compared to its original position. So here in this picture you can notice that the canine and the first premolar are exhibiting the gingival recession, and not only gingival recession, they are also having minimal keratinized tissue. So both the teeth are at risk for the further recession because of the gingival inflammation present, and also the arrow mark is pointing at the frenum, right? So there is frenal pull also. So they are at risk of further recession taking place. Next finding is the marginal bleeding. So marginal bleeding takes place because there is inflammation in the marginal gingiva. So how do we evaluate the marginal bleeding? We can evaluate that by running a periodontal probe into the gingival margin. So under pressure, the healthy gingival tissue will not bleed. Okay, it will only blanch. Whereas if the inflammation is present, the marginal gingival bleeding is observed. So the ease and the severity with which the bleeding takes place is correlated with the severity of the gingival inflammation. In case of healthy condition, there will be only blanching and not bleeding, whereas in case of diseased conditions, there will be bleeding. Next one is suppuration. So here in the picture you can see that the purulent exudate is expressed from the periodontal pocket by the digital pressure. So the palpation of the marginal gingiva with the probe, or by digitally placing the ball of the index finger on the gingiva apical to the margin, and when we push it coronally towards the gingival margin, a white yellowish exudate may be seen from the gingival crevice. Next, we will see the tactile examination of the gingival crevice. So in this, we will place the probe vertically into the gingival crevice, and the probe should be in contact with the tooth surface as we pass the probe around each tooth surface. So this is called as walking the probe. So by walking the probe, we will determine whether there are any irregularities. We will know whether there are any tooth surface irregularities, if subgingival calicles is present, or there is furcation invasion. So all these we can detect. And also, while passing the probe, we need to pay attention to the tactile feel of the gingival tissue and the tooth surface. So here, if the gingiva is healthy, then near the probe tip you will be feeling that the gingival tissue is tight and it is resisting the probe penetration. So attention should be paid to all these features. So attention should be directed towards detecting the presence of periodontal defects, craters, and furcation invasion. Next is the attached gingiva. So we need to measure the width of the attached gingiva. So as we have all seen in the topic of gingiva, the attached gingiva extends from the end of the marginal gingiva to the mucogingival junction. So it is important to establish the width of the attached gingiva. So the methods include, by retracting the cheek, we will be knowing the mucogingival junction position. We can assess the width of the keratinized gingiva. Later we can subtract it from the sulcus depth. So all these techniques have been discussed in the topic of gingiva. The other techniques include the staining method with the help of Schiller's potassium iodide solution. Next, we need to see about the wasting diseases of the teeth. So these include the gradual loss of the tooth substance. So the forms of wasting are erosion, abrasion, attrition, and abfraction. So here in the first picture you can see the non-carious cervical lesions, and these are a combination of abrasion, abfraction, and erosion. Whereas in the second picture you can see the flat shiny discolored surfaces which are produced by the occlusal wear. So erosion, the term erosion is also called as corrosion, and it is a sharply defined wedge shaped depression which is present in the cervical area. Whereas abrasion refers to the loss of tooth substance that is induced because of mechanical wear other than that of the mastication. Whereas attrition, as you all know, is an occlusal wear that results from the functional contact with the opposing teeth. So you need to examine for the wasting diseases of the teeth, that is erosion, attrition, abrasion, and abfraction. Next, we will examine the alveolar bone loss. So this alveolar bone loss can be evaluated both clinically and radiographically. So first we are performing the clinical examination, next we will go for the radiograph. So first, how do we examine the alveolar bone loss clinically? That is by transgingival probing. So you will be anesthetizing the tissue. So after anesthesia is given, you need to pass the probe into the gingival crevice, and then by the tactile sensation you will be knowing the height and the contour of the facial lingual bones and the architecture of the interdental bone. So the transgingival probing is performed only after the area is anesthetized. Remember that. So here in the picture you can see that as the probe is passed you will be able to detect the bony architecture, right? Next we will be seeing about the furcation invasion. So we have seen the Glickman's grades of furcation: grade 1, grade 2, grade 3 and grade 4. The probe that is used to detect the furcation is the neighbors probe. So in grade 1 there is intact interradicular bone and the bone loss is incipient, whereas in grade 2 it is cul-de-sac, in which there is loss of interradicular bone and pocket formation, but there is no through and through. Whereas in grade 3, through and through lesion is present. Whereas in grade 4, there will be through and through lesion. It is same as grade 3 with the gingival recession. So all these grades of furcation have been discussed in the topic furcation. Next, we need to evaluate the dental stains, whether dentinal hypersensitivity is seen, proximal contact relations, trauma from occlusion, if the teeth have pathologically migrated, sensitivity to percussion, dentition with the jaws closed, and also functional occlusal relationships. Next, we will see about the tooth mobility. So all teeth will have a slight degree of physiologic mobility. So this physiologic mobility will vary for different teeth and at different times of the day. Usually when we wake up in the morning, so when arising in the morning it is greatest and it progressively decreases. So this increased mobility in the morning is attributed to the slight extrusion of the teeth, because during the sleep there will be limited occlusal contact, isn't it? So because of this limited occlusal contact there is slight extrusion of the teeth. So that is why in the early morning we will feel the, like after arising in the morning we feel a little bit of mobility. Okay, so during waking hours the mobility is reduced because of the chewing and swallowing forces, due to which the teeth get intruded, right? So the tooth mobility is graded by holding the teeth firmly in between two handles of the metal instrument. So in between the handles of two metallic instruments, or it can be done even with the help of handle of one metallic instrument and one finger, as you can see in the picture. So next we are seeing the grading of mobility. So this was given by Miller. This is usually followed. So mobility number 1 indicates that it's the first distinguishable sign of movement that is greater than normal, whereas in 2 the movement of crown is seen up to 1 mm in any direction, whereas mobility number 3 indicates the movement of the crown more than 1 mm in any direction, or there is vertical depression or rotation of the crown in the socket. So the physiologic mobility is the movement up to 0.2 mm horizontally and 0.02 mm axially. So mobility beyond this physiologic range is termed as abnormal or pathologic. So you need to assess this mobility. Next, we will see the radiographic examination. So the radiographic survey should consist of a minimum of 14 intraoral films and 4 posterior bite wing films. So panoramic radiographs can also be taken. They are actually a simple and a convenient method, and they are very much helpful in detecting the developmental anomalies or any pathological lesions in the teeth and jaws or in the fractures. So these panoramic radiographs will provide an overall radiographic picture, but in cases of periodontal diagnosis and treatment planning, a complete intraoral series of radiographs is required. Next, we will see the laboratory aids to the clinical diagnosis. So after this clinical and radiographic diagnosis performed, then if there are any unusual gingival or periodontal problems which cannot be explained by the local causes, in such cases we will go with the laboratory aids. So what are these? These are the analysis of blood smears, blood cell counts, white blood cell differential counts, erythrocyte sedimentation rates, coagulation time, bleeding time, clot retraction time, prothrombin time, and capillary fragility. So all these tests can be performed depending on the situation. Next, we will go to the second topic, that is the prognosis. So prognosis means prediction. Okay, it is a prediction of the course, duration and outcome of the disease based on the pathogenesis. So based on the pathogenesis we are performing, or we are predicting what is the course of the disease, duration of the disease, and we will be assessing the disease based on the pathogenesis and the presence of risk factors. Okay. So there are different classifications or the classification schemes that are given for prognosis. So I will be discussing about one scheme. You can remember this. So first one is good prognosis. So if there is adequate control of etiologic factors and there is adequate periodontal support for the so that the tooth will be easy to maintain by the patient as well as the clinician, then it is called as good prognosis. Whereas there is 25% attachment loss or if there is grade 1 furcation, then it is fair prognosis. Whereas if there is 50% attachment loss and grade 2 furcation, then it is poor prognosis. Whereas if there is greater than 50% attachment loss, poor crown root ratio, poor root form, grade 2 furcation or grade 3 furcation or mobility number 2 or 3, or if there is root proximity, then it is called as questionable prognosis. If there is inadequate attachment in order to maintain the health, comfort and function, then it is hopeless prognosis. So remember that good, fair and hopeless prognosis which are present in this classification system can be established with some amount of accuracy. So poor and questionable prognosis are likely to change because they depend on the large number of factors that can interact in an unpredictable number of ways. So good, fair and hopeless can be given with some amount of accuracy, whereas the poor and questionable differ depending upon different factors. Next, we will see the factors that we need to consider when we determine the prognosis. So first one is the overall clinical factors. So we need to know the patient's age, the disease severity, biofilm control by the patient compliance to the treatment. So next one is the systemic and environmental factors. If the patient has a habit of smoking, any systemic disease or condition is affecting the outcome of the periodontal therapy, if there are any genetic factors or stress involved. Next, we need to see the local factors, that is a biofilm and calicles, subgingival restorations if any present. Next is anatomic factors. If there are short tapered roots, cervical enamel projections, enamel pearls, bifurcation ridges, root concavities, developmental grooves, root proximity, furcation invasion, tooth mobility, caries, tooth vitality, root resorption, and also need to observe the prosthetic and the restorative factors. So when we talk about biofilm control, it's very important. So because biofilm is a primary etiologic factor, right, for periodontal disease, so effective removal of this biofilm on a daily basis by the patient is very much critical for the success of the therapy. And patient compliance and cooperation is also very important because the patient's attitude towards the treatment, their desire to retain the natural teeth and their willingness to effectively participate in the biofilm control is very important. So patient complaints and cooperation towards the treatment is very important. And regarding smoking, we all know that smoking has very much deleterious effect on the progression and development of the periodontal disease. So it should be made clear to the patients that there is a direct relationship in between smoking and the periodontal disease. Therefore, prognosis in patients who smoke and have slight to moderate periodontitis is usually questionable. In patients with severe chronic periodontitis, the prognosis will be unfavorable or hopeless if they continue smoking or if they have the smoking habit. Next, in case of systemic diseases or conditions, they also affect the overall prognosis of the patient. Next is genetic factors, stress. So all these will influence the prognosis. So in case of caries, tooth vitality and root resorption, so for the teeth that are mutilated by extensive caries, we need to consider whether the restorative therapy, that is endodontic therapy, can be performed before undertaking the periodontal treatment. In cases where there is extensive root resorption, that is because of orthodontic therapy, so that will decrease the stability of the teeth, so it will adversely affect the response to the periodontal treatment. So in such cases we need to evaluate whether these can be treated or not. So root resorption, tooth vitality and caries should also be taken into consideration. Next, we will talk about the overall prognosis and individual prognosis. So, prognosis can be divided into two, that is, the overall prognosis and the individual tooth prognosis. Overall prognosis is concerned with the dentition as a whole. So, the factors that influence the overall prognosis include the patient age, severity of the disease, systemic factors, presence of biofilm. So, all these what we have seen earlier. So, this overall prognosis, when we perform the overall prognosis, we need to determine whether treatment can be undertaken. If treatment is undertaken, will it be a success? And when prosthetic replacements are needed, are the remaining teeth able to support the burden of the prosthesis? So this is what we need to determine after the overall prognosis is estimated. Later, the individual prognosis is performed. So individual tooth prognosis is determined after the overall prognosis, and it is affected by the overall prognosis. So for example, like in a patient with a poor overall prognosis, the dentist would obviously not like to attempt a tooth that has a questionable prognosis because of the local conditions. So the individual tooth prognosis is performed after the overall prognosis is done, and it is affected by the overall prognosis. Here we will see a clinical situation. So what do you think? The prognosis of tooth A is better or prognosis of tooth B is better? So, the prognosis of tooth A is better when compared to the prognosis for tooth B, in spite of having less bone on one of the surfaces of tooth A, because the center of rotation of the tooth A is closer to the crown when compared to the center of rotation of tooth B. Because the center of rotation is closer to the crown, the distribution of occlusal forces to the periodontium is more favorable in A tooth when compared to the B tooth. And another point I want to explain is about the patient's age. We all have seen that patient's age is very important in determining the prognosis. So, if suppose a younger patient and an older patient having the attachment loss and the alveolar bone loss with the comparable levels of the attachment and alveolar bone loss, the prognosis of the older patient is good when compared to the prognosis of the younger patient. Why? Because the prognosis of the younger patient is not so good because the patient is younger, and in such a short time frame the periodontal destruction has occurred, whereas for the older person, even though having a greater age when compared to the younger one, the periodontal destruction took a long time to take place, whereas in the younger patient the time frame is very short. So the younger patient, the prognosis is not as good when compared to the older patient. So here I'll give an overall view. So first we are examining the patient, we are giving the patient a diagnosis, later we are estimating the prognosis, and depending on that we are performing the treatment. Okay, so diagnosis requires thorough and careful examination. Prognosis is based on accurate diagnosis, and the treatment decisions are based on prognosis. Treatment decisions are made in order to improve the prognosis. Okay, and diagnosis and prognosis will again change with the treatment. So this is the sequence. So the important questions from this topic include, you need to know what are all the diagnostic aids that are to be used, you need to know the sequence, you need to know the importance of the medical history in evaluating the periodontal condition, you need to know about the bleeding on probing, how to evaluate the width of attached gingiva, you need to know the factors that influence the prognosis. Those are very important: the overall clinical factors, the genetic factors, stress. So you need to remember all these factors. You need to remember that there are two types of prognosis, that is overall prognosis and individual prognosis, and the individual prognosis is performed after the overall prognosis. So you need to remember all these points. So these two topics are especially important for your multiple choice questions. Thank you everyone for your patient listening.